morning, everybody. Welcome to tonight's Woo You event. This is the very last event of 2025. So I just want to personally thank everyone who has attended all of the events we've had since January. It's been a wonderful year here at Woo You. If things look a little different, it's not your computer. We have a brand new platform that we are debuting. We debuted last night, so things may look a little different, but we'll go through that in the housekeeping slides. So welcome again to tonight's Woo You event, contact lens complications in a primary care setting with Dr. Elise Kramer. How are you, Dr. Kramer?
I'm good. How are you?
I'm good. What a way to end the year with another Woo You favorite.
Thank you. It's so nice to be here again.
We're happy to have you again. I'm your host, Dr. Jennifer Stewart. And thank you to Contimac for exhibiting at tonight's event. So just some reminders, and this may look a little different. For a CE certificate, please fill out the survey. The link will be posted in the chat and also emailed to you after the event concludes. Attendees must be online for a minimum of 50 minutes per hour of credit. CE certificates will be delivered via email and sent to ARBO with your OE tracker number. Please allow for up to 4 weeks for certificates to be emailed. There will not be a QR code tonight in tonight's event, but if you're here, you'll get that certificate emailed to you. So this is where things get a little different. Q&A and handouts can be found at the top right-hand side of your page. To minimize, use the down arrow, and to open, use the chat button. That's where you can put your questions for Dr. Kramer that we'll have time to answer at the end. So once again, I'm honored to present Dr. Elise Kramer. She earned her doctorate in optometry from the Université de Montréal in 2012. During her study, she participated in a humanitarian mission to Morocco, where she provided free eye exams and glasses to hundreds of individuals in need. In her 4th year, she completed an internship focused on ocular disease at the Eye Centers of South Florida, followed by a residency at the Miami VA Medical Center, which included training at the renowned Bascom Palmer Eye Institute. After her residency, she became a fellow of the Scleral Lens Education Society, where she now serves as vice president. Additionally, she's the vice president of Women in Eye Care, a member of the American Optometric Association, the International Association of Contact Lens Educators, and is a fellow of both the American Academy of Optometry and the British Contact Lens Association. She's an accomplished author, having published numerous articles and reviews, and she actively participates in clinical research trials. She's passionate about education, lectures internationally in multiple languages on topics related to ocular surface disease and specialty lenses. Welcome on this side. She's also a Woo You moderator, so welcome on the other side. I'm going to turn it over to you. I will be in the background, and I will see you at the end.
All right. Thank you so much. It's so nice to be here. I'm going to share my screen here, so bear with me 1 second. Hopefully everyone can see this now. And can you just confirm that you're seeing my screen, Jen? Dr. Stewart?
It's still loading for me.
Okay. It's still. Let me know if you see it there.
I still see loading, so we'll just give it a moment.
Okay. I can try again. 1 second, share screen, and let's do this.
Oh, somebody else said they can see it, so it must be on my end.
All right, can you see it now?
Still loading on my end, but I will check with others because it could be me.
Good to go, Dr. Kramer. Thank you.
All right.
You have it shared?
Attendees can see you're great.
Okay, amazing. Thank you so much. So thank you again, Woo You, for this amazing opportunity to talk about one of my favorite things, actually probably my favorite thing, which is contact lenses. Obviously not complications themselves, but, troubleshooting contact lens issues. And, I think it's really interesting that we're going to do this in primary care. I'm a contact lens specialist, but I do see a lot of primary care patients. And whoever is here and listening that is, practicing mostly primary care are seeing a ton of contact lenses, right? And they're not just, the soft disposable ones, but also RGP lenses, scleral lenses, hybrid lenses. Even if you're not the one fitting them, you may be seeing patients with these lenses. And so it's so important to understand some of these complications that can come up and be able to identify them and perhaps how to troubleshoot them as well. There's actually 140 million contact lens users globally, and primary care ODs are the first line of defense. So a lot of the time, people are traveling or they're having an emergency and need to find someone more local, and they will come to primary care to troubleshoot complications. So again, so important to know these things as they come up. And obviously there's so many different types of contact lenses, but we all know about soft lenses, and this obviously can be a soft disposable lens like you're seeing here in the photo, but it can also be a soft custom lens. It can be a soft hydrogel or silicone hydrogel lens. So many different kinds of soft lenses. And there's hybrid lenses, which, as you can see, are rigid in the center, but have a soft periphery or soft skirt, the gas permeable contact lens, and then the scleral contact lens. And these are the main kind of 4 different types of contact lenses that you'll see. There's variations of the soft lenses. We have more rigid soft lenses, softer soft lenses, but in general, this is what we have. And so let's start with the soft lens complications. And the reason why I wanted to start with this one is because really in primary care, this may be the type of contact lens that you're seeing most often. As I mentioned, you will see other types of contact lenses as well, but the soft lens is so common in primary care. And so I wanted to start with this one. And so Claire, and I always remember this one because my mom's name is Claire, but anyway, this is the contact lens acute red eye. So this is not an infection. It is a acute non-infectious inflammation, often upon awakening, associated with extended wear of soft lenses. Patients will report sudden redness, pain, tearing, light sensitivity. Usually there's not an epithelial defect, and this is actually often caused by gram-negative endotoxins. And so the management would be to stop the lens wear, maybe some steroid drops, and also switch to dailies and stop the extended wear. So I love talking to my patients about daily disposable lenses. A lot of the time, in optometry, we don't want to fix things that aren't broken. If we have patients that are using some of the oldest lenses on the market and they're super happy, but, I always like to plant the seed and talk to my patients about the newest technology, even if they're not keen or have no motivation to switch. It is something that I like to bring up because I want them to know what the latest and greatest is. But if they have a complication like this, switching to daily disposable definitely makes sense. All right, so this one is super common. And honestly, if you flip the lid, which I think is so important in all contact lens patients, just flip the lid. But you know what? I flip the lid in everyone. But really in your contact lens patient, it is so rare to not see this. So this is GPC, giant papillary conjunctivitis. It is an immune response to lens deposits or mechanical trauma. So it is actually a type 4 delayed hypersensitivity reaction. It is very common with reusable soft or even hybrid lenses, and patients will complain of itching, mucus discharge, foreign body sensation. It is very uncomfortable. And a lot of the time, if you're not flipping the lid, you're thinking, okay, this may be dry eye. It's not necessarily always itchy, but if you flip the lid, you will find this so often. And what you're going to see is papillae on that upper tarsal conjunctiva. The risk will increase with poor hygiene, protein buildup. Essentially what happens is your soft contact lens accumulates all these deposits, especially with lenses that are not daily disposable or even 2-week disposable. It's a longer, more extended lenses or more conventional lenses are going to accumulate proteins, lipids, and that interacts with the upper eyelid, causing more friction, causing this delayed reaction. And the more papillae you have, the more friction you have. So it's kind of this vicious circle of friction and hypersensitivity and accumulation of deposits that just keeps going until it's interrupted. And so I actually like to switch a lot of my patients to a peroxide type of solution if they have this issue. But a lot of the time, what I may do also is switch them to daily disposables. Again, I think this is something I highly recommend in these patients. And they can also use mast cell stabilizers or combination, allergy, antihistamine, mast cell stabilizer combination drops to help minimize this type of reaction. But essentially, switching the modality to a daily disposable, and if they really want to stay in the monthly, I mean, switching to a peroxide solution is really what we do. But again, flip the lid, guys. You will see this very often, and it all starts with actually thinking about flipping it, because the itchy eyes, the mucus production, foreign body sensation, a lot of this could mimic other things. And if you don't flip the lid, you might miss it. So definitely flip the lid in all your contact lens patients. If that's one takeaway you can leave with this evening. All right, so continuing on, corneal neovascularization, super common as well. And the reason I put this photo and not like a blatant, like super neovascularized cornea is because we don't really see a lot of those super neovessels very often, but we see these small little vessels starting to creep inside the cornea very often. And this is caused by chronic hypoxia, which stimulates new vessel growth in the cornea. It's going to be more common with the low decay lenses, patients who sleep in their lenses. Yes, they do. And even if you ask them, they might lie about it. So definitely try to probe them to find out if they're sleeping with them. Because they do not, obviously, this is a complication that we want to avoid. It is often asymptomatic early, but there's definitely a risk of vision loss because those vessels will continue to grow. They can creep into the visual axis. They can leak as well. And so these are things that need to be taken care of initially. And the thing with neovascularization is it doesn't really fully go away. So if you switch to even a daily disposable or a higher decay lens, patients often will still have these neovessels, but they will empty and become ghost vessels. So it's important to kind of tackle this early on before it causes changes in the corneal and in the cornea itself. You can detect this via slit lamp. You can also see this on OCT angiography, looking for deep stromal vessels, pannus, and again, the management, discontinue wear, maybe for a little bit, but refit with a higher DK or even a daily disposable higher DK lens will help remind patients that they should never be sleeping in their contact lenses and that they should also maybe take breaks if you're seeing this issue. Okay, MK, and MK is something that can happen with any type of contact lens. And the reason why I put it here with the soft lenses is because the highest incidence is with soft lenses. So you can get MK with an RGP, a scleral lens, a hybrid lens. It is less common. It is more common with a soft lens, but this is a complication. Obviously, a little scarier, a little more sight threatening than the other ones previously mentioned, but something that can occur definitely in any type of contact lens. So this needs to be treated like an emergency. Pathogens, usually Pseudomonas, which 2-3 days can actually go right through the cornea. So something that really needs to be taken care of. It can be acanthamoeba, it can be fungi as well. And so it's important to, culture if possible. Patients will experience severe pain, discharge, light sensitivity. You'll see this white corneal infiltrate. You'll see an epithelial defect. The risk increases significantly with overnight wear and with water exposure. I mean, if you're having patients with water exposure, that's where we see the acanthamoeba. I personally have had a few cases of acanthamoeba in my office. It is a scary thing, but it can occur and it is not a joke. Patients love to sleep with their contact lenses. They love to swim with them. They go to the spa. I mean, these are all conversations that need to be had. So you'll see that epithelial defect. You'll see the stromal infiltrate, which is really the hallmark. And if you can get this cultured, that would be great. It's honestly just to rule out anything that is not bacterial, right? So acanthamoeba, fungi, or even herpetic, right? But you want to discontinue lens. So there's no contact lens wear at all. You can start broad spectrum antibiotics. And if you see that they're not responding to antibiotics, that's when I usually refer to culture, because I don't culture in my office. Honestly, the acanthamoeba and fungi or fungus reactions, fungal reactions will have kind of a different appearance in the bacterial reaction, but I'm not going to go through all the MK presentations, but bacterial is really this type of image that you see here. Is this kind of round infiltrate that you'll see centrally or paracentrally, and that's really usually bacterial and usually Pseudomonas. Okay, I love this slide because we really don't see this anymore, but I find this so interesting. These are deposits that we would see in the 1980s. I'm not going to say we, because I wasn't seeing patients back then. But that they were seeing in the 1980s. And really, these are deposits that you see with these thick hydrogel extended wear conventional lenses that we really don't see that much, but you might see these things. And that's why I love to bring this up and show you, because you may get this in your clinic and be like, what is this? I've never seen anything like this before. And that's when it's interesting to know that this can actually occur. So jelly bumps or mulberry deposits, those were thought to be composed of a combination of mucus, lipid, protein, and calcium. And you can see that on slide A. Iron deposits, you can see protein deposits in C, and obviously these are a little bit lower resolution, and you can see those calcium deposits on D. And just to show you, I actually had jelly bumps on a patient last week, so you can still see these today. This was a patient who had chronic progressive external ophthalmoplegia, and she had blepharoplasty done on both eyes. She has all this exposure. So they gave her a bandage contact lens, and she was wearing it as extended wear. I mean, she was not removing it at all. She left it on for 3 months. And finally, she came to me to have it removed. And when I removed it, I saw these jelly bumps. So it is not SPK. So it's not punctate keratitis. You actually don't have a loss of cells there, which is what punctate keratitis is. But you will get pooling of that fluorescein, and it does have a different appearance. It is usually will go away with, just artificial tears and obviously removing that lens. But it is interesting to see, and just to show you that this is something that you can still see today. All right, so this is kind of a joke, but not, because patients still try to put on and take off contact lenses, even with nails like this. I've seen it personally. But there's a lot of great videos on YouTube where you can see these types of things. But obviously, it's definitely a battle of long nails versus contact lenses, and usually the nails win. And this is an abrasion. I mean, you can see abrasion from a ton of things, not just contact lens, application removal from poor handling or long nails. But it's interesting, and taking a proper case history and looking at your patient's nails and seeing how they're doing it can really point to maybe we need to cut the nails or clean them better, or switch to a different method of putting it in, because this is not a good combination. Okay, microcysts are going to be intraepithelial cysts from chronic hypoxia. So again, those lower DK extended wear lenses, which we're not seeing as often today, but it's important to know how to identify this. It might look like a Kogan's dystrophy, but it will resolve after you discontinue lens wear. It's usually asymptomatic unless they're very numerous. And you can actually best see this with retroillumination, as you can see in this image. And again, just switching to dailies. I feel like I'm going to say that this whole section of soft lenses, but switching to dailies, higher DK, or even switching to a rigid gas permeable lens. So when you have a rigid gas permeable lens, again, it's gas permeable. The DK by definition is high, and you get that tear exchange. So the cornea can grab its nutrients not only from the oxygen, but also from that tear exchange that we're getting. which we may not be getting as much with a thick, extended wear, low DK lens. All right, moving on to RGP lenses, and this is just a classic low resolution, old school 3:9 staining photo that we've all heard of. And the 3 o'clock and 9 o'clock staining is just drying and those horizontal meridians. It's due to incomplete blink, lower edge lift, lens decentration, so just a poorly fitting lens that has this desiccation on the side. It can lead to infiltrates. I mean, obviously, you have these epithelial defects on the sides, and that can lead to infection. So whenever we see an epithelial defect, no bueno, right? And so it's something that we want to treat. So it can also lead to pinguiculitis, discomfort. So it's going to improve with blink training. So a lot of our patients, again, on screens are not blinking enough, and that can just cause desiccation. They may not feel like they need to blink, again, because they're on a screen, because they have this barrier on top of the eye. But blink training, so complete closure when they're on screens, and probably a lens edge redesign is what I would do, and just remind the patient to use artificial tears, preservative free, especially when they're on screens. But in this case, you can really see that the fit can be improved. If you are in primary care not fitting RGP lenses, maybe tell them, hey, I'm seeing this staining, I'm going to treat this staining, but I want you to go back to your specialist, and sounds like you need to, or it looks like you need to have this lens refit or redesigned. Okay, dimple veiling. So I love these words, they're so unique, but these are circular divots in the cornea that you will see by air bubbles trapped under the lens. And so when there's air under the lens, so usually you have this tear layer or tear kind of reservoir, if you will. Obviously, the real reservoir would be with the scleral lens, but it's going to be this tear layer that you have between the RGP and the cornea. And it should be a uniform layer of tears. But if you have bubbles there, that is the absence of tears, and it's actually air. And that creates small indentations in the corneal epithelium, often due to a very steep fit or excessive clearance. But it can also be due to a patient not putting on their lens properly. Like a lot of the time, if you ask patients how they're putting it on, they're putting it on the side and then pushing it up, and it's grabbing all this air as it goes onto the cornea. That's not the right way of putting on an RGP lens. It should be put directly right on the cornea, and it shouldn't be kind of slid from the conjunctiva to the cornea. So also look at application removal, because a lot of the time the fit might be great, but they're just not putting it on right. And some patients do have to put in a drop in their lens before they put it on. But it can be due to a steep fit, excessive clearance. It is asymptomatic, and it will resolve after lens removal. So in the photo on the left, you can see what it looks like with the lens on. And the photo on the right is with the lens off. It does look like staining. It is not staining. It is just pooling of fluorescein in those kind of dents that we've made in the cornea, and it will go away. The management is to flatten the fit, reduce lens clearance, and I'm also going to add that maybe reviewing application removal, adding a drop to the bowl of that RGP before putting it on. All right, warpage, super common, and our ophthalmology friends hate this, because if they ever want to do cataract surgery or any type of refractive surgery on a patient, I mean, this is their worst nightmare, because now we have to take patients out of their RGPs for extended period of time until their cornea takes their normal shape back. The good news is that the cornea will take its shape back eventually, but this is essentially distortion of corneal shape from chronic lens pressure. It is seen with long-term RGP wear, certainly seen if patients are sleeping again with their lenses on. And yes, they do sleep sometimes with their RGP lenses on, unfortunately. It does cause blurry vision. It can cause fluctuations because the corneal shape will change throughout the day. We can diagnose this easily with a topography, but on the left, you'll see kind of what it looks like when you have a lens that's just not fitting right and causing all this irregular fluorescein pattern, which kind of reflects what we're seeing on the cornea. So this is reversible, thankfully. discontinue the lens and monitor for corneal recovery. But again, not ideal, especially for our surgery colleagues. If we ever want to have a patient do surgery, having them not wear a lens for an extended period of time just so their cornea can take their regular shape back is not ideal. And also getting these patients into glasses is really difficult. And I do, as much as I love contact lenses, I do think all patients should have a spare or the possibility of wearing glasses if they can, especially if they have a normal cornea. I mean, they can wear glasses on off days, on days that they don't want to wear RGPs, but having corneal warpage really prohibits them to have a kind of precise measurement or reliable glasses measurement. And so not ideal. All right, let's go to endothelial and epithelial changes. So this is called a bleb response. These are transient dark spots that are seen on the corneal endothelium minutes after lens insertion, especially rigid lenses, again, caused by hypoxia, mechanical stress. We are seeing this less in those higher gas permeable lenses or higher DK lenses, usually asymptomatic. It does resolve after lens removal. It's not harmful, but it does indicate stress to the corneal endothelium. So this matters, if we have patients who have corneal transplants or we have patients who have a compromised endothelial cell count. So definitely something that can happen. And it can lead to microcysts as well. In these cases, just using the higher DK, we have so many available materials on the market that are high DK in the 190s and the 200s. So we're really lucky today to have this and rarely see this. But a lot of patients, personally, I'm seeing, and here in Miami, I have a lot of patients from Cuba and other countries, and also in South America, where they don't necessarily have access to higher DK materials. And so I do see hypoxia a lot. And so just switching these patients over to something a little bit more modern, higher DK materials can make a huge difference. All right, we are going to move on to hybrid lens complications. So a lot of the time we're seeing SPK, peripheral staining. This is going to be localized epithelial damage, as you can see in this photo, often inferior temporal. And this is going to be from poor edge alignment or a very tight skirt. So remember that these lenses have a rigid center and they have a soft skirt. They may indicate inadequate tear exchange or hypoxia. So before, the skirts used to be a lower DK hydrogel material, and now actually we have higher DK soft skirt materials, which has helped a lot with hypoxia in these cases. But a lot of the time when you have a poor edge alignment, you can still see that staining. So check for lens decentration, a tight fit, or also handling issues. And as a reminder, if you do have a patient who has a hybrid lens, ask them to remove their lens and also stain the cornea without the lens on if you're seeing them, because that's when you see everything kind of lighting up. In these cases, to fix this problem, we want to loosen the skirt curve or switch to a daily wear schedule if possible. So this skirt rigid mismatch will cause discomfort. We can have the rigid center and soft skirt that will be misaligned with the ocular surface. That can lead to poor lens stability, poor centration, edge lift as well. Especially if they have edge lift, they're going to feel awareness of the lens. They're going to feel foreign body sensation. They can also have fluctuating vision. And so these type of lenses definitely need to be readjusted. The skirt curvature, sagittal depth, or lens design itself might need to be changed. And so here on the first image, you're seeing an OCT, so an anterior segment OCT of the lens on the eye with a skirt that's too steep at dispense, and then OCT post lens dispense shows the lens has settled too much and now bears into the cornea. So you can see at the beginning when we first put it on, it looks good, and then after a while it kind of just sits there when it shouldn't be. And in the second image, you have an OCT of a hybrid with an inner landing zone bearing, leading to lens adherence, and basically that can cause a lot of discomfort, can cause staining as well. So again, just a reminder to remove those lenses and check the cornea for your patients. So how do we diagnose these things in primary eye care? I mean, you really don't need much. You definitely don't need an anterior segment OCT. If you have one, that's amazing. But you really just need to take a case history, find out if patients are sleeping with their lenses, find out what solutions they're using. And you need a slit lamp fluorescein. And obviously, I love the Ratten filter. I'm a huge fan. You can really see the difference in the enhanced contrast when you add a Ratten filter, and the photo at the bottom is a perfect example. So if you just use your cobalt blue, you'll see a little bit maybe, but look at the enhancement and how much contrast you can really see and how much that brings out the staining when you have that Ratten filter. And of course, lid eversion, super important, right? And the anterior segment OCT, if you have it, but definitely not necessary. So don't stress if you don't have an anterior segment OCT. Again, we're talking about primary care. So everyone has a slit lamp, everyone has a yellow filter, everyone has cobalt blue, and everyone has fluorescein. And so this is how we identify. All right, best for last, because I love scleral lenses, but we're going to talk about scleral lens complications. So you can see this photo here. We actually see a huge indent on the conjunctiva. This is caused by a scleral lens that was just completely indenting into the conjunctiva. It is reversible, but it can cause pain and redness. And we're going to talk a little bit about all the different complications, or most of the complications that we can see with scleral lenses. All right, hypoxia. So we are going to see hypoxia as well with scleral lenses. So this is a situation where sometimes we have, again, patients with compromised endothelial cell count. But the etiology is, again, reduced oxygen transmission to the cornea. So even though scleral lenses are gas permeable, they don't allow the same tear exchange that RGP lenses do. And then the reason is because they're completely vaulting over the cornea and landing on the sclera or on the conjunctiva, overlying the sclera. And that will cause this poor tear exchange. It actually takes about 8 hours to completely replenish the tears in underneath the scleral lens. And that will cause just this situation where we really don't have any nutrients coming from the tears and everything comes from the air. So now we have a few barriers. We have the scleral lens, and between the scleral lens and the cornea, we have this tear film reservoir, which also relatively reduces the oxygen transmissibility. And so what are the symptoms of hypoxia? Reduced vision. We can have light sensitivity or photophobia, colors around lights as well, hyperemia, and troubleshooting. This was based on a study that was done by Dr. Michaud. Reduce the clearance, so reduce that vault to a minimum. Obviously, it still has to vault the cornea. So we don't want the scleral lens touching the cornea, but we do have to have a tear film reservoir that's not too high because that will limit the amount of oxygen. We can also reduce the lens center thickness. So there's no need to have a lens that's super thick. We can reduce it to a center thickness of 0.2, sometimes 0.3, and that's usually good enough. And utilizing high decay materials. So again, we're really lucky now. We have, decays of 150, 180, 200 that really allow a lot of oxygen through, but the clearance and the center thickness are going to be limiting factors. So oxygen transmission and tear exchange are important considerations for patients who have compromised endothelial cell count, so post-graft patients, or Fuchs endothelial dystrophy or other dystrophies that can affect the corneal endothelium. All right. So if our lens is touching the limbus, so the lens itself can rest on the limbus, that can actually cause stem cell stress. So we'll see this as fluorescein staining on the limbus. So important, if you have a patient with a scleral lens that comes into your office, it's important to remove the lens, even if you're not fitting it, even if you're not the one who designed it, remove the lens and look at the cornea, look at the limbus, look at the conjunctiva. Now we're seeing this touch on the limbus due to the lens settling over time. So a lot of the time when the patient is in that contact lens specialist's office, the lens looks great, but then after they leave, let's say 4 hours later, we can get that settling and that will cause the touch. So patients may be asymptomatic, but they can also have redness and discomfort. So it's important to address this. If you see it, send them back to their specialist to have this resolved. In this case, we can increase the limbal vault and we can recheck after settling. So a lot of the contact lens specialists will like to see their patients 30 minutes and sometimes up to 4 hours after they have their lenses on, in order to look at this, the limbus itself and the settling of the lens. All right, so MDF or midday fogging, it is something that if you are fitting scleral lenses, you are going to see this. Unfortunately, it is super common and it is also not easy to resolve. Our colleague, Dr. Maria Walker in Houston, has a PhD on midday fogging. It is amazing the work that they do there, and I recommend reading some of those papers. But this is what we see on the slit lamp. And again, what we can see on the anterior segment OCT is basically all this dense kind of material that you can see in that tear film reservoir between the cornea and the lens sitting on top. And it is, patients do not like this. I mean, they will feel like it's hazy, they will feel cloudy. And now even if the vision itself is clear, it's like a clear cloud, and you know, it's very uncomfortable. And so we really try to resolve this as much as possible. So usually what happens is fluid dynamics under the scleral lens, and this attracts deposits in the tear film reservoir. Sometimes if the limbal clearance is excessive, or you have no tear exchange, so that's debris accumulation over time. We can also see this if you have excessive edge lift, and that will just cause so much debris to just come underneath the lens. And a lot of patients will also report, in addition to seeing the cloudy vision or hazy vision, they will report that they need to remove their lenses in the middle of the day, sometimes multiple times, in order to get rid of this. And it doesn't fully get rid of it. It comes right back. And again, who wants to be at work or wherever and have to remove their lenses, put it back on? Removing scleral lenses and putting them back on is not like just, you know, opening a blister pack of a daily disposable lens and popping it in. You need plungers sometimes, you need saline. It's a whole thing. And so not convenient for patients. So it's something that we really want to resolve. The first thing that we do is assess and treat any ocular surface disease. And so this is not an ocular surface lecture. Wu Yu has so many amazing ones that I highly recommend you go see. But ocular surface disease is so common. I mean, every other person has Demodex blepharitis, I feel like, and blepharitis and MGD and allergies, and all of this stuff causes inflammation, and inflammation really does cause a lot of debris accumulation in the tear film instability. And so the first thing I do is treat the ocular surface disease, because even though I have all these fun tools and amazing scleral lens technology, it doesn't matter if the patient has dry eyes or inflammation, they will have this issue. But sometimes, you know, despite them doing an amazing job taking care of ocular surface disease, they still have MDF. And so we can modify the peripheral curves, reduce the diameter of the lens sometimes, flatten the curves to minimize the impact on the conjunctiva, modify the curves to reduce limbal clearance. And sometimes they still have fogging, even though, you know, the lens looks great, it's not causing problems. And so sometimes we can mix a little bit of viscous solution or viscous artificial tears inside the bowl of the lens with saline. And that kind of helps keep the debris at bay. I think it also helps get rid of some of those inflammatory cells that we can see based on the studies that I've read. You can also ask patients, so this is in the literature, to replenish the solution from the side I haven't seen a benefit from that, but that is in the literature, so it's there. But again, removing lenses and replenish with saline midday, which again is not ideal. And on top of that, I feel like it causes a fishing syndrome where the more you apply and remove the lens, the more debris you get because you're just kind of messing with the ocular surface even more. So again, we're not wanting patients to have to remove their lens. My goal is always for them to be able to wear their lens from morning until night, until they feel like removing it, and not because they have midday fogging. All right, so that's what it looks like again, anterior segment OCT. And so theory one would be poor edge alignment, which allows tear debris to enter the reservoir, but not escape, which leading to buildup over time. And the second theory is rapid corneal cell turnover, which causes epithelial debris to become trapped behind the lens, especially if the filling solution irritates the ocular surface. So those are the two theories. Of course, this is an evolving space, and there's constant kind of new studies coming out, new information. So definitely read up on that. But this is a problem that we see very frequently with scleral lenses, unfortunately. And so there's so many ways to assess the edge lift. And so if you do see a patient who has a scleral lens, I encourage you to actually put fluorescein on top of the lens as well. And you'll be able to see maybe where this fluorescein is coming in through and where it's seeping in, where it's sealed off. And you can see so many different patterns that are really interesting. And it can really give us a lot of information about how these scleral lenses are fit. So you just paint the front surface of the lens with sodium fluorescein, and then you can look where the tear exchange is and where it's not happening, and maybe where you have too much edge lift, for example. What does an ideal scleral lens looks like? Well, these are two photos that you can see here with white light on the top and white light on the bottom with fluorescein. So ideally, you don't want to have any interruption of circulation, so no blanching of blood vessels. You don't want to have any impingement, and you don't want to have any edge lift either. Now, the scleral shape is very unique. So for years, we've been fitting the cornea, right, with our RGPs and our soft lenses. But now we're really bypassing the corneal curvature and now trying to fit a shape that is much more odd sometimes. And the scleral shape can be different in everyone, of course. And even in the same eye, you can have different meridians that have different shape. And so this is what happens when you try to fit a spherical lens on a against the rule scleral toricity, right? And so you can see that edge lift kind of on the sides, and you can see that it's too tight vertically. And so these areas of poor misalignment can cause discomfort, rebound redness. This is the debris in the tear film reservoir. And so what we can do in these cases, we can actually steepen the horizontal meridian, we can flatten the vertical meridian, and a lot of times we can customize lenses a lot more than just that. We, again, are very, very lucky to have a lot of amazing technology today and ways to, modify scleral lenses in ways that we couldn't before, and adapt these lenses or adjust these lenses to the specific scleral shape that we encounter. And scleral toricity is most patients need some sort of toricity in their scleral lens in order for the lens to fit properly. And so these photos will show you what severe edge lift looks like. And edge lift is just uncomfortable for patients. They feel it when they blink. It gives them a lot of foreign body sensation, lens awareness, and then it does attract a lot of debris under the lens. And then you can see cases also of mild impingement, severe impingement, where we get that seal off or the interruption of conjunctival vasculature, which over time can lead to just staining of the conjunctiva. It can lead to rebound redness, discomfort, difficulty removing the lens, and can also attract debris underneath the lens. So we have ways of troubleshooting this with quadrant-specific lenses. We can share photos with our consultants. We have these amazing tools available that can help us design scleral lenses to fit a lot better than we used to be able to do. It was a lot of trial and error before, and now we have fancy stuff that can help us fit these lenses. We also have the ability to do an impression of the eye now and design a lens that is completely freeform, that is based on this impression, do a 3D printing of that lens and have it kind of designed specifically for that patient's eye. So it's really amazing what we can do today. And so a lot of the time, our lenses are fitting quite well, much better than they used to. So a little bit of dry eye for you. Obviously, on top of the lens, we do have our tear film, right? And the tear film has to be pretty stable in order for light to go through properly. And so if you have an unstable tear film, your patient will not be happy. So again, going back to ocular surface treatment, but so important that even if you have an amazing scleral lens, you really do have to treat dry eye and make sure that lipid layer is good quality. So you need to have an even continuous pre-lens tear film, and this will help a patient be comfortable. This will help them have the best vision. So even if you're using the best materials and surface coatings, this is something that we really need to push our patients to achieve. And the patients do have dry eye. And even if the scleral lens itself hydrates the ocular surface with the tear film reservoir, you can still have a unstable tear film on top, right? So the poor lens surface wettability is something that we can really see a lot. Again, the first thing we do in these cases is manage the lid and ocular surface disease. Review the skincare regimen, because some patients are putting their lenses on when they have, all this amazing cream on their faces and makeup. No, the lens has to go in first, and then the skin routine or the makeup after. We can improve this by using peroxide-based solutions. You can clean it with the Q-tip or a DMV plunger, which is kind of a squeegee method, we like to call it. Not ideal either. Selecting a material with a lower wetting angle sometimes help. All lenses now are plasma treated, most likely. And then we also have HydroPeg, and HydroPeg is something that can help improve the interaction of the surface of the lens with the tear film. So what does this come from? Mucoid lipid protein coating on the lens surface. Kind of reminds you of what I was talking about with that at the beginning with the GPC and the protein and the lipid accumulation. And although we do get less protein and lipid accumulation on hard lenses than we do on soft extended wear lenses, we can still get it. And so this causes dryness, blurred vision. I mean, imagine seeing through that, right? Not comfortable. Again, frequent lens removal, which is not convenient. And so I was talking to you about HydroPeg, and this is a plasma treated lens. Okay, the surface is not wettable, the tear film is unstable, and we can see what it looks like after adding HydroPeg, and it's so beautiful. And we also have a solution that can help boost the HydroPeg. So after it fades, it kind of like recoats the lens with another surface. So this is a great tool, but again, don't neglect the ocular surface. It needs to be treated, whether or not you have a good fitting lens, whether or not you have HydroPeg. This is so important to treat the ocular surface. But you can also have a surface with a million scratches, and this is honestly something that just comes from patient education. This is improper cleaning tools, patients using maybe like a toothbrush to clean their nail, to clean their lens, a fingernail, an abrasive cloth. Some patients also get this by putting their lens in the case without solution first. So the solution is like a cushion, right? So if you always have to put the solution first and then the scleral lens after, to avoid the lens kind of banging up against the sides of the case. This will not improve with blinking. Patient may have awareness also just because that surface is rugged and it's causing more friction with the eyelid. And so it definitely needs to be replaced. Not much we can do for this lens, unfortunately. So just replacing the lens. And you just can't iterate enough how important it is to remove that lens at every visit. Even if you're not the one who designed the lens, you're seeing this patient remove the lens, and you can see sometimes staining that's a diffuse staining on the surface of the eye. This is not normal. Obviously, this is due to usually entrapment of preserved product under the lens, exposure to preservative agents, which patients, they confuse a solution sometimes. Instead of using saline, they're using contact lens cleaning solution. Sometimes they are sensitive to different solutions, preservatives, preserved artificial tears, or other drops that they may be using with or without the lens. But really check what solutions they're using. That's usually the culprit. But again, avoid using preservatives, ensure proper use of saline solution, just go over it with them. Check that they're rinsing the lens with saline prior to putting it on. Some patients, again, are sensitive to the different cleaning products and they have to rinse off the lens. Checking compliance at each follow-up is super important. So I always remove the lenses. I look at the cornea at every visit and educating the patient. Make sure your technicians or whoever is working with you is on board and knows the solutions and can walk patients through this because it's super, super important part. And then we have obstacles on the conjunctiva, which do not prohibit the use of a scleral lens. We can still fit a scleral lens, but a lot of the time we have pinguecula, pterygia, some blepharons, glaucoma blephs, hypertrophy. And so in these cases, we really either want to minimize that scleral lens interaction or completely avoid these obstacles. And so we have different tactics available for this. So this is not really, I would say, a complication. It can be a complication if you fit a lens that doesn't have any avoidance tactics on it. So if you're just kind of putting a spherical lens on a patient that has these obstacles, you probably will get some issues. But there's so many ways that we have now and so many technologies available to avoid or kind of gently glide over these obstacles. And then, some patients have difficulty putting on their lenses because they may have deep set like sockets, very prominent brows, tight lids, just like super kind of hyper blink reflexes, phobias, Bell's phenomenon, dexterity issues, Parkinson's, or other tremors, joint issues, deformities. And, this is actually the same scleral lens in the same patient, but they just put it on differently. And so the top image looks like this lens is like super tight and is impingement 360 and is causing an interruption of conjunctival vasculature all around. But actually, no, they just like shoved it in their eye too hard. And so it caused that type of seal off. And so important, to go over application and removal the right way and just softly put it on. It doesn't need to be like pushed into the eye so hard. It fits fine, and it just has to be gently put in the eye. So again, application removal. And sometimes, they put on a scleral lens and they get that air underneath. And going back to what I was saying before about the dimple veiling, you can get a huge dimple veiling with a scleral lens when you have these big bubbles. But again, this might just be due to them not putting enough saline in the bowl, the lens, the saline spilling when they're trying to put it in, especially when they're learning. But my thing is, if they can get a lens in with a bubble, they can get a lens in without a bubble. So it's just about putting an overflowing amount of saline, maybe leaning over a little bit more, and just knowing how to see if they have a bubble and feeling it so that they can remove that lens and avoid that dimple veiling. And then a lot of the time, they're having these distortion or blur, even with a scleral lens, and that can be from residual astigmatism. So that's not necessarily a complication, but it's something that we can see, and it has to be corrected. And we assume, scleral lens is going to neutralize irregular astigmatism. So why do they have astigmatism after? Well, it does neutralize astigmatism, but sometimes only up to 90%, which is still huge. But they could also have lenticular astigmatism. They could also have a tear layer distortion. Maybe the lens is not fitting right. Maybe it's decentered. Maybe it's misaligned. So sometimes just improving the fit, so the peripheral alignment of the lens can help with that. But optimizing the tear layer, maybe a larger optic zone, or adjusting the curves. But sometimes we do have to put a front toric on a lens, and that's usually to correct any residual astigmatism from the cornea, maybe from the posterior surface, or also lenticular astigmatism. So we do a spherocylindrical over-refraction in these patients. And so education is super important. Having tools like this, just like little sheets that you can give your patients. Don't overwear, don't sleep with them, don't swim with them, don't spa with them. And, we change our underwear every day, so we can change our contact lenses every day. Sanitize your contacts, change your cases, no water exposure, replace your lenses as you're supposed to, and try, if especially in soft lenses, daily disposables when you can, I think is really the move. So soft lenses are the most common source of complications, so especially MK. But always rule out infection first in red, painful eyes. For RGP hybrid sclerals, usually the fit itself is the diagnosis and the treatment. And hygiene and follow-up is your best prevention tool. So hand washing, using the right solutions, and just following our patients and asking the right questions every time they come back. So that's it for me. I will stop sharing, and I think, yes, I'm on time.
You did a great job. Thank you. You were perfectly on time. So.
Did you get to see it, or was it loading the whole time?
On my side, it was loading, but I know that everybody else saw it, so it was
Okay.
on our side. But we do have a few questions that came in.
Okay.
So there was a question about GPC, and the question was, what about switching to a non-Sci-High material?
Yeah, so I think that's possible. Also, we can switch to a material that's not silicone hydrogel. So the silicone does attract a little bit more deposits than just hydrogel lenses. But the silicone hydrogel has so many benefits. Like they wet better, they are newer, they have higher decay, and I prefer to have my patients in silicone hydrogel lenses unless they're daily disposable. So honestly, in cases of GPC, my first move, if they don't want to switch to a daily, would be to use a hydrogen peroxide solution first, and then, ideally switch them to a daily. That's kind of what I would do.
Perfect. Let me just find the other questions. There was a question about lens warpage with PMMA lenses.
Yeah. So, does PMMA cause warpage, or?
I think so. I think that's the question.
Okay. So, PMMA lenses, which we really don't see a lot anymore, didn't only cause warpage, but the main issue there was hypoxia. And so that's actually why scleral lenses kind of went off the market for a while, because everything was PMMA, and they did reduce the diameter to smaller diameter lenses to allow more tear exchange. But we do get warpage even with PMMA lenses. And honestly, that is not really a material that's used today.
Perfect. Let me see. There was another question. What do you use to culture ulcers? What is your protocol?
So I don't culture anything. If I suspect that it is bacterial, I will put them on an antibiotic every hour, broad spectrum. And then I'll see them back pretty frequently, usually like the next day if it's bad, or 2 days later if I'm comfortable with it. And if I don't see an improvement or it looks worse, they're going directly to get cultured. Or if it has a presentation that is not consistent with bacterial keratitis, I will send them immediately for a culture. I may not put them on an antibiotic in that case, because then the culture will be a little bit better done. But I don't culture myself.
Perfect. And the last question, what is a lens haptic?
Okay, so I think that is talking about a scleral lens. So a haptic is a fancy way of saying a toric peripheral curve. So when you talk about haptics in scleral lenses, we're referring to the peripheral curves themselves. So the edges of the lens and how those curves need to be modified in order to improve the fit. So you can steepen the haptics, you can loosen the haptics. And so that's what a haptic is, which is very different from an IOL haptic. So you cannot copy paste there, but it's essentially talking about the peripheral curves in a scleral lens.
Perfect. Well, with that, that is the end of the questions that we have. If you have more questions, stay tuned because we've got another opportunity for you to ask those questions. Thank you, Dr. Kramer. Thank you for ending the Woo You year on such a high note. Yay! But we have such great content planned for 2026. So while this may be the last webinar for this year, stay tuned. There's a lot of great webinars coming up for the new year. But thank you to everyone who has joined us, and thank you to Contimac for exhibiting at this event. So make sure you stay tuned to learn how to get a complimentary contact lens companion. Reminder, there's no QR code tonight. That's usually the top asked question. No QR code tonight, so your certificate will be emailed to you within 2 to 4 weeks, and your attendance will be reported to ARBO with your OE tracker number. So thank you for that.